in children and young adults. She also diagnoses and treats primary brain tumors in pediatric patients and cares for children with NCM or neurocutaneous melanocytosis, which is a condition seen in some patients with large CMN. So thank you for joining us today. We will start the session with a couple questions that we received in advance. So the first question that we have is, I guess we'll just start out with probably our most common question, which is about surgery or removal of nevus or nevi. I guess the first question is, what would you suggest people, what's your common recommendation? If you have a patient who's considering nevus removal, do you generally suggest it, or what are some considerations that parents or patients should have in mind when discussing nevus removal? We'll open this up to all of our panelists, so whoever wants to go first can jump in.
Dr. Bauer, I think you are muted.
All right, try that again. The choice about whether we treat or not treat is certainly up to the family to make the decision, as well as, what the timing for when we do surgery. I think that the patterns of large and giant nevi are very repeatable. So over a long period of time, it's possible to have, a fairly distinct outline of what exactly is going to have to be done if we do surgery. But the two questions are, one, there is some thought that are consistent in the literature that there's no significant risk of melanoma or other malignancy in large and giant nevi, or that the surgery doesn't warrant however little the risk is. And the fact is that that's not really the case. I think long term, we do see a benefit of surgery. And then you have to balance that plus just the aesthetic issue, what the effect is of, the nevus in terms of how the child develops long term, and how they're addressed and what problems they have to do psychologically. So even small nevi can cause significant problems from an aesthetic standpoint. So I think that, our way of approaching it is we tell them what can be done. And with the right experience, it's possible to show them pictures of near identical or larger nevi and how that gets done. And then let them make the decision as to whether it's something they want to do or not.
Yes, I would agree with Dr. Bauer. I think it's a, really, there's no one recommended way. It's really kind of shared decision making with the patient and the family and the care team in regards to, what that surgery would look like, what the outcome would look like, what the process would look like, what the goals of the family and patient are. So there's many kind of facets that kind of go into it as far as what the best approach is to each individual person.
Great, thank you for that. And I just wanted to remind participants that you can submit any questions that you have in the Q&A. This is a panel, so we welcome anything you have. Dr. Khakoo, did you have something to contribute to that? I think you're raising your hand. The technical difficulty. Okay. So the next question that we had submitted is asking about NCM. Well, a lot of times we hear about NCM being screened for and diagnosed in children, but we have some people involved in nevus outreach who wants to know if it can develop later on in life and if adults should be screened for NCM. So I think that's probably best for Dr. Khakoo if you're able to answer that question. But of course, if anyone else would like to chime in, feel free.
Is she there?
Yes. Okay. Yeah, there we go. We can hear you now.
One sec. Let me just put on my AirPods because there's a lot of background. Okay, can you hear me?
Yep.
Okay, cool. So thanks for organizing this and for all the people to joining in. The question I wanted to answer a little bit before that was, I've had the question asked about surgery. Should we be biopsying or removing nevi just to get genetic information about the nevus? And I am a big proponent of no, that is not a good reason to take something off. If you're concerned that it could be malignant, if your dermatologist or your surgeon is worried about that, that's one reason to do it, but not to just biopsy it so that you can say that you have an NRAS mutation or a BRAF mutation or some other kind of molecular change in the nevus. Because it doesn't really tell us anything more than what we already know about these nevi, is that most of them do have an NRAS mutation. And I'm assuming you all know what that is, but I'm going to put it in the chat. So it's only to the host and the panelists, but oh, there's the Q&A. Yeah, but whatever. So the question you asked about is, does NCM develop later in life? And what I always tell patients is that, you know, you can have a normal MRI and a normal child and a large nevus, and you can still have areas in the brain that we don't appreciate on the MRI. And we wrote a paper on this a while ago because one of our patients needed surgery for a seizure issue. And when the surgeon went in, he saw that there were areas of deposits of neurocutaneous monocytosis in areas of the brain that we were not actually able to appreciate these lesions on the MRI. So, you know, what we see is, you know, helpful to some extent, but it's not the full story. So if you're asking me, will people develop it later in life? They may become symptomatic from it later in life. They could, you know, have a seizure, or they could have some kind of neurologic issue, but it's not because the nevi are growing or changing. It's really just the way someone's brain is wired. The other thing I always tell people is that, you know, we're not, when we do the MRI at the beginning, you know, when the child is first diagnosed, we're just doing that as a baseline. We're not doing that to dictate any therapy or any prognosis, because even if we see small lesions, little spots, what I call spots on the skin, spots in the brain, it doesn't really tell us who's high risk to develop really severe complications like CNS melanoma or hydrocephalus or seizures. It doesn't really tell us. So that's what our registry is trying to collect now, is to see, is there a pattern here of which patients go on to have a guarded prognosis or a more serious event. And I just want to introduce my colleague, Shidobe Omeasor. She's a medical student working with me this year on this project for the summer. And she's, you know, joined in just to learn and hear. And she's been great. We've been looking again at seizures. We collected, the registry opened in September 2020. We expected to accrue 70 patients in 7 years. So 2027, we should have 70. We actually have 45 or 46 patients to date. And so we're going back now and looking at who had seizures and what the outcome was. So it's, you know, a long-winded answer to saying we don't think that's the problem. The problem is, like, what are the drivers causing these, what molecules are there that are causing patients to have, you know, more severe disease.
Just one piece to add to that, I think if people are doing research, you will find some quotes about risk for melanoma associated with the presence or absence of neuromelanosis. There's data out of the UK from Veronica Kinsler's group, kind of risk stratifying people based on the presence of congenital neuromelanosis versus absence of that. So I just wanted to put that out there as kind of another piece to that puzzle, that there is some data, but I understand, Dr. Khakoo's point is that there's a lot more to investigate, and that was a select population that was screened that generated that data.
Great, thank you for that. Our next question that was submitted earlier this week was asking about long-term follow-up for somebody with CMN. Do you recommend they regularly see a dermatologist, or what other specialists would you recommend? And if so, how often would you recommend surveillance?
Really quickly, Lily, as well, I'm going to interrupt and just remind attendees that in case they would like to submit a question anonymously, that is also an option. When you go to the Q&A box, you can click a box that will submit it anonymously. Thank you.
Yeah, from the dermatology angle, yes, we do recommend long-term follow-up. We know that people can have kind of no symptoms with their nevi, or can develop symptoms over time. Also, there is kind of an ongoing risk, particularly for people who have large, giant, multiple congenital nevi for melanoma. So we do recommend in adults an annual check-in for those patients. Now, the answer would be different when thinking about people who have small or solitary medium CMN. For those, typically they can be followed with regular visits to the primary care physician, and not necessarily need specialist care. The other piece to consider is, so for some people who have had excisions or removal, either kind of total visual removal or partial removal, we know from a lot of studies that there's still likely pigment cells within the skin, even if visually it looks like all or almost all of the nevus is gone. So we do still recommend follow-up. Now, it may be for people who've had the vast majority of their nevus removed and don't have complicated scarring. Potentially that could be with their primary care provider. But for folks who do have a decent amount of scarring or kind of more complicated scarring, again, dermatology follow-up would be recommended.
Great, thank you. Our next question will probably be for Dr. Khakoo again. It reads, if a child is diagnosed with NCM who has had developmental delays and recently possible seizure activity, what is the typical recommendation for follow-up MRI to be completed in these children? Is it possible for lesions to develop in the brain further after an initial MRI completed when under 6 months?
Hi, yeah, so what was the question again? It blanked out for a second.
Yeah, I'll read it. If a child is diagnosed with NCM who has had developmental delays and recently possible seizure activity, what's the typical recommendation for follow-up MRI to be completed in these children? And is it possible for lesions to develop in the brain further after the initial MRI completed when under 6 months?
Right. So the recommendation for re-imaging any child with a large nevus, we recommend initial imaging under the age of 6 months, because then we can better appreciate any areas that have neurocutaneous melanocytosis. And it kind of gives us a baseline, but we don't typically recommend re-imaging. No matter what we find on the MRI, we don't recommend re-imaging unless the child develops a neurologic condition like seizures, like hydrocephalus or symptoms of hydrocephalus, or some developmental regression. So just say they were walking and they're not walking now, we would recommend evaluation by a child neurologist, and then decide, what neuroimaging needs to be done. So if a patient already has seizures or may have seizures that develop, at age 2 or 3, we recommend at that point to please re-image with an MRI with and without contrast, because there's a possibility that there's a new area that we would continue to watch, or maybe even take out if we thought it was potentially a melanoma. So again, I don't know. I don't think Veronica Kinsler's re-images unless there's an issue either, because at this stage, if we had like a magic bullet answer to fix neurocutaneous melanocytosis or large nevi, that might be a reason to continue to scan people. But We know that it's not the nevus itself in the brain that's really the problem. That's just a marker of how the brain grew and developed. And it's really like, even if you could take a, white out and just white out all the spots in the MRI in the brain, it wouldn't treat the underlying brain development issue, which we think is a marker, that the nevus is a marker of that. So if you look, for example, that child we had the surgery on, who's still doing well, he's alive, is I think almost 20 now, but he had surgery when he was 3. If you look at the tissue, when we took out that part of his brain that was potentially causing the seizures, when we looked under the microscope, it wasn't just the nevus that we could see on the surface. We looked at a very detailed look of what the architecture, how the brain developed. And we all have, the same architecture plan, but our children can sometimes have a very different architecture that causes some of the things like seizures or developmental issues. So for a patient who has newly symptomatic NCM, we definitely would recommend re-imaging. Now, how often to do it once they have seizures and once they have a situation, sometimes seizures can be difficult to control regardless of the reason, whether it's related to, a patient who just has seizures, who has no large nevus, none of these kids are not here, just any child with seizures. We don't image those children repeatedly because we're not sure what we're going to do with that information, because unlikely that things are going to change. So if your child developed seizures, had an MRI that looked stable, didn't suggest anything concerning, and was on medication and, was having like flurries of seizures, in the first few months after starting, I wouldn't jump to say, let's go re-image that something's changed. If we get good control of the seizures and, a year or 2 later, the seizures start getting more frequent, and it's not just because the baby has gotten larger and outgrown their dose of anti-seizure medicine. It's they're on a good dose. If we start having flurries of seizures later, we might say let's re-image again and see what is there something new that we're missing. Does everybody know what a seizure is? Because I haven't been on any of the other talks this morning or today.
I think people probably have like a general knowledge because these are mostly patients and their family members, but not like the understanding. Probably.
Yeah, I mean, basically we have, when I want to move my left hand, my right brain sends a signal to my left arm and it moves. Some patients in the world have something that's causing the right side of the brain to kind of have involuntary firing of neurons, like they just are doing it on their own, and I have shaking or jerking of my arm. Other patients can have full body seizures where everything's jerking and shaking. Some patients can have a space out episode where they're not paying attention. So all of these are kind of activities of the brain that are not typically seen with people. I don't like to use the word abnormal because it's kind of a trigger word, but it's just different, right? So that's what happens when you have a seizure. Some part of your brain is giving a signal to your body that shouldn't really be giving that signal. And children can be born with seizures without large nevus, without NCM. Some patients, might have a car accident and have a brain injury, and that can cause a seizure. Other patients can have seizures because of a genetic condition. Our patients with NCM and LCNN, they're typically not congenital. I mean, they're not familial things. These are what we call sporadic. They happen randomly. So we don't have to be concerned with other members of the family having this. So that's that.
Great, thank you. Next one, how can a scalp nevus lighten, but the hair growing from it is still dark? If anyone has an idea for that one, please feel free.
I don't know if we fully know why that happens. One thing that we know about congenital melanocytic nevi as we follow them over time is that, initially at birth, they can even look more kind of blue or red or even more kind of vascular. And then the color can kind of change to be more brown or black. And then the nevi will sometimes go through this transformation where they will lighten to kind of the baseline pigmentation of the individual. And so if an individual has, let's say, like red hair or blonde hair, lighter skin color, sometimes the nevus will go from more brown in color to maybe light brown or tan or kind of tan pink in color based on the pigmentation of the individual. I would think that, there might just be more kind of collection or of melanocytes in an area, and maybe that hair is darker. It'd also be interesting to know what the individual's baseline hair color is, and perhaps the hair within the nevus is following that same kind of pigmentation pattern.
Yeah, when I think about it similarly to what happens in vitiligo and what happens to the hair when somebody has vitiligo. So vitiligo is loss of pigment, typically caused by inflammation, but the hairs in the areas with vitiligo can be reservoirs of pigment. So when we think about getting the color back, if you will, for vitiligo, you're calming down the inflammation, but where is the color? It actually will kind of expand from around hair follicles. So it's possible that these regressing nevi, or potentially regressing nevi, because we don't have nice serial biopsies on people, which, as parents could imagine, no 2-year-old is volunteering for that. But that's how I kind of think of it, is that the hairs are likely potentially acting like they do in vitiligo, as being that last reservoir of pigment. And that's how you can still have that pigment there, whereas the rest of the skin around the area has lightened significantly.
Great, thank you. Another one that we previously received was, how can patients impact or support advancement in CMN research?
I think that there's, many different ways that patients can help advance research. I mean, I think one, participation in studies that are available. If there's ideas that you have, talking with researchers, helping, get funding. There's different funding that kind of oftentimes takes into consideration kind of patient kind of advocacy groups, patient participation, as well as researcher participation. And I think increasing awareness as well is really important of certain kind of disease states, especially ones that are more rare. So increasing awareness in your community, Nevus Outreach has been wonderful, I think, in a group that kind of helps support research, fund research, and that is largely driven by patients and families and their participation and advocacy.
Yeah, I can put in a plug too for the upcoming PEDRA meeting that Maggie mentioned a bit ago. So that's going to happen in November. That's the Pediatric Dermatology Research Alliance. It's going to happen in November, and it's actually open to patients to actually register and attend. So if you are Southeast and local and interested in kind of seeing these discussions and being present and meeting other families with a variety of other skin conditions that may be there, that's another way to kind of start to network and be in the room when some of these discussions are had and interact with the physicians and researchers that are going to be present. But like Dr. Khakoo mentioned, her registry is going to be super impactful. So if you've got NCM, thinking about signing up for that. And then as Maggie mentioned, if we do get a kind of registry 2.0 off the ground through Nevus Outreach, that would be another way to be available.
Dr. Khakoo, did you want to add something? If not, I'll jump to the next one. I think this would be best probably for Dr. Bauer. And yeah, Dr. Khakoo, you're not muted right now.
Oh, good. Okay, thanks. What I want to say is, yeah, great ideas. I didn't realize Pedro was patient, they had patients there, so that's really good to know. The other thing is, if you have any tissue taken off anywhere, if the part of the nevus or, somewhere, it's really good to shuttle parts of that tissue to certain reliable registries, like Pittsburgh with Dr. Miguel Rose Mujica. He has a really big registry of tissue, and he has been able to identify a lot of, some of the changes we see in these nevi. Our institution now, once we have seen a patient and register them to the registry, we also register them for any tissue that's removed later in life, that they could send that to us and we can do some special testing on it. So if you hear your child wants, if there's something that's coming off, or maybe for cosmetic or whatever reason, just give that a thought. And most of our, like Dr. Bauer, I've sent your team kits of blood and stuff to get for us, and it works really well. We can now do it, some of the tests with saliva, but babies cannot produce a whole teaspoon of saliva very easily, although they do drool a lot. It's hard to catch it. So sometimes we can use nails or hair, but from a baby who's going to have surgery, if they're getting an IV anyway, the blood is the easiest, safest thing to do, and we can just get sent to us, and then we have that with the tissue to look at, what's in the tissue, what are the molecules that are driving the nevus to form.
Great, thank you. Next one, probably for Dr. Bauer. Can I get my plastic surgeon, or can I get any plastic surgeon to remove my nevus, or should I try to find a CMN expert? And what are the risks and side effects of getting my CMN removed?
Well, I think we all develop specialties, and, again, coming back to the issue of the fact that these are still fairly rare lesions compared to a lot of other things that plastic surgeon might treat, or any other person might treat. And in order to not only have a set game plan of what needs to get done, and be able to give some, rough idea of how many procedures that may take to remove it, but also, to understand how the surgery impacts where the scars are going to be, what the long-term effects of those scars are in terms of growth and development, and just the aesthetics as well. So I don't think that any plastic surgeon should be doing this. I'm not a cosmetic surgeon, as you suggested, but someone who just does aesthetic surgery, not reconstructive surgery, and works with kids, to be able to not only see the procedure through, but be able to get a long-term follow-up to see which procedures work best, why did one work better than the other. So I think it's important to go to a specialist. I think that one who, since the best way of replacing most of the nevus tissue is with tissue expansion, someone who has experience doing that, and understands why that's a better choice than, say, trying to do serial excision and repeated surgeries in the same area. So yes, it's important to go to someone who has experience, and also someone who can discuss the implications. As far as the risks of the procedure, the main risk is, if we're using tissue expansion, is infection during the time the expander is in place. That occurs about 5 to 7% of time. It's rare for it to impact what the outcome is going to be. And today, even though these are big procedures, they're all done as outpatient surgery. It doesn't require patients to stay in the area a long time. So it's worth traveling, not necessarily just to see me, but anybody who has enough experience doing this. And I think it's important for the patients to be able to say, this is what my child has. Can you show us some samples of what's involved to better understand what the process is? And in order to accumulate that kind of information also takes a lot of time and experience.
Great, thank you for that. Next one is about NCM. My 3-month-old daughter had an MRI last month. She has NCM on both right and left temporal lobes. Her neurologist is wanting an MRI after 3 months, and then when she is a year old. She's asymptomatic. Should we decline? Probably Dr. Khakoo again. Yeah, you're unmuted.
So, one of my jobs is to help people around the country and around the world make the best decision for their child and for their patient. So, I actually see patients without any charge to get them on the registry, to give them the information. Because, now that we have telehealth, some of this is a lot easier. Unfortunately, our government isn't reimbursing unless we have a medical license in that state. While during COVID, they let us see everybody. But I'm much more interested in helping people than worrying about a dollar sign, where my boss would probably think differently. But, so what we do is we can either do a mail review or we can do a peer-to-peer. And peer-to-peer means we can talk with your treating team to figure out what's best for your child. And so I don't want to say you should refuse the next MRI. I would say, could you please talk with somebody like Dr. Khakoo or Dr. Pichon? He's at Mercy Children's, he's another expert, to discuss whether my child should have another scan, because I heard that, unless you're symptomatic, we don't usually read in it. I'll give you the other side of the story is that I've seen children, age 15, 16, who've had an MRI every year for the first 5 years of their life and had like some little speckles on their MRI. And then finally they stopped imaging them. And then at age 15 or 16, something happens and they have a seizure, and then there's something new. So I don't think we're preventing anything from happening by doing these MRIs. I think we're learning more about who does need to have an MRI more frequently. And when you guys come to me, or, my partners, basically we'll tell you that, anytime you need anything, we're here for you. And we give you two important things to notice. So if your child is having signs of hydrocephalus, which hydrocephalus means that the fluid in all of our brains that's normally there sometimes doesn't flow normally in patients with NCM and some other kinds of diseases. We're not going to get into that, but for this conversation, it's for children with large nevi. Sometimes their fluid doesn't flow properly, even if their MRI at birth looked the same and normal, didn't have any changes. So if they need to have a diversion procedure, which is called a shunt, some of your children may have that. We would like to know about that sooner rather than later, because we've had a few cases where children have developed lesions in the abdomen where we shunt the fluid into. So now we ask that anybody who's getting a shunt or any kind of cerebrospinal fluid diversion, just ask their providers to call us so we can help manage that with you. One thing we've been doing is doing imaging of the abdomen if somebody is going to need one of these shunts. And these shunts are surgically placed. I'm not going to get into the details right now, but if you hear the word shunt or hydrocephalus and you have questions, just call us, email us, whatever, and we can try to work with your team to do the best possible treatment for that. There's another procedure that can avoid putting a shunt in, but a lot of times those aren't used because the child is really not feeling well, and they just need to fix this problem quickly. And the second thing is, if your child has to have some kind of immunosuppression, and when we talk about immunosuppression, so your immune system is always scavenging, and everybody in this room has immune cells that fight cancer all the time. We don't know that there's cancer there, but we just know that the immune system is really, really important. So sometimes we have patients, one of our patients had a condition where they had to have things like lupus, juvenile rheumatoid arthritis, inflammatory bowel disease, these things that need heavy suppression of the immune system because their bodies are kind of attacking themselves. We've seen a patient who in that setting had immune suppression and developed a brain melanoma because we think their body wasn't able to fight the melanoma that was kind of trying to be there. So we want to know about that. And The reason we want to know about that is, listen, if you're going to have immunosuppression for something, we have other treatments that are just not chemotherapy, but they're IV treatments or oral treatments that can actually help your immune system continue to fight the melanoma. So there's like a balance. So those are the two things. If your child has to have a shunt placed, or if your child has to have immunosuppression. And I'm not talking about a little bit of steroids for asthma or topical steroids for eczema, not that kind of immunosuppression. I'm talking about big treatments like that they have to get every month.
Great, thank you. The next question was asked at one of our sessions earlier today, but we just wanted to see if anyone else had any thoughts. They asked your thoughts on red light therapy to help with scar healing or repigmentation along the scar line or general skin health. So anything about red light therapy that you guys know of?
Well, a laser, regardless of the type of laser, can sometimes long-term be quite effective in dealing with lightening a scar that may not over time have, during its maturation, darkened. I think that very often the patients that we see, laser may be suggested in a very early period following the initial procedures when things have not even had a chance to mature. And the point being that, you're going through treatment that may not be necessary given enough time. I think that it is certainly effective in scars that may remain pigmented over a long period of time. And I'm not as convinced as the effectiveness for hypertrophic type scars, but it has a role. I don't think it has a role. Certainly don't think it has a role early on in the treatment. It may, deal with scars in more visible areas that are slow to mature, and we have a nice thin scar, but it's in a spot where, because of the color remains, it's more visible. In a situation like that, if the child's old enough to be concerned about that, and also then able to go through laser treatment in an office setting, I think it has valid use.
Yeah, I know I have more experience with laser and thinking about laser than I do specifically about red light therapy. I think the folks may be kind of reading about a visible light therapy with kind of devices that may be either FDA cleared, not necessarily approved. And I would say I have not seen literature on them specifically in like the CMN population. So I couldn't really make a comment on that, but I do know there's kind of more about that for a variety of things skin-wise in the press nowadays.
Thank you. Do you have any advice or recommendations for new parents, just from each of your own practices and perspectives?
I think that having a child with a larger congenital or larger giant congenital myasthenic nevus, initially there's not a lot of literature out there, but Carrie and myself, there is a paper in Pediatrics from 2021 specifically about care of the newborn with a larger giant congenital melanocytic nevus, and in that literature recommendations. There are some expert recommendations about which specialists to seek out. I think seeking out a pediatric dermatologist or a dermatologist with kind of expertise in treating CMN is important early on. I think they will be a great resource as far as kind of explaining kind of natural progression and who to refer you to as well. Sometimes we would think about referrals to neurology or ophthalmology as well, just to kind of get plugged in with those specialists. And then having them, seeing them frequently, especially in that first year of life, perhaps every 3 months, to see how the nevus evolves and to kind of examine it and palpate it as well. There's recommendations regarding just gentle skincare or regular kind of skincare with emollients, and bathing practices, as well as using sunscreen and sun protection. And the recommendations around those would be to use sun protective clothing, hats, especially for the first 6 months of life in general, but definitely within the first 6 months of life where we don't typically use sunscreen. It's not as recommended, and using, sunscreen and sun protection to the exposed areas after that, after 6 months of age.
Yeah, I think another thing would just be kind of recognizing that congenital nevus is probably not something that was expected before birth. There's super rare reports of people that identified it on ultrasound beforehand, but that is like the far exception rather than the rule. So knowing that, like, it's okay if you're feeling surprised or stressed, you're dealing with a new baby, you're not sleeping, all of the feels, it's fine to feel all of the feels, but to know that you have a supportive community. If you want to engage with other families, great. If you don't want to engage with other families, great. It's kind of, each person has their journey and things may change over time, but knowing that you have a group of providers that you can call on, you've got Nevus Outreach to go to for resources. And then knowing that kind of early on, particularly if your child has large, giant, or multiple congenital nevi, there's going to be kind of a lot to do early on in terms of the frequent visits, like Dr. Gupta was talking about, and some kind of early decisions about screening for NCM. That kind of busyness will calm down over time, becomes more normal, and there are fewer, sometimes, depending how things are going, maybe fewer decisions to be made. So that's good. If there are more decisions to be made because of stuff that was found, fine, you get plugged in with people, as you were hearing from Dr. Khakoo. I mean, she's like, yeah, call our office. We're happy to engage with your providers. So you've got a network that kind of stretches across the country, that is willing to help out regardless of kind of where you are.
Yeah, just want to emphasize that like Yasemin, this is something that we've been doing for ages, longer than most of you have been around. But we look at the problem the same way she does, in terms of the fact that while our institutions would like us to have a license in every state we ever talk to anybody with, we don't believe in charging for that information. We're happy to answer questions. We have PowerPoints that will cover any nevus in any area. And it's just email and photographs, and that we don't recommend specifically us, but the fact is that we can give enough information to be able to compare different approaches. And then we have ways of supporting them coming to us from out of state or out of country. But the most important thing early on is the information that parents get from somebody who has some experience seeing these things, and being able to see how they behave long term, to be able to have some framework to make a decision on it.
Yeah, all these are really important points. And, the first thing is love your baby. We talk about the rule of fives in my clinic. Some of you here may have heard that. So when the baby is born, the first 5 minutes, your baby will probably be diagnosed with the nevus, right? Because they were just born. The next 5 hours will be kind of trying to figure out, is the baby doing well? Are they breathing? Are they, crying appropriately? And then, should we get the dermatologist in to see the kid? The first 5 days, after you take the baby home, can be extremely joyful, but can also be stressful, because you've got now not just, like Dr. Coughlin was saying, not just a newborn, maybe this is your first child, and now you've got family members who are trying to be helpful, but maybe are not being so helpful because they're asking a ton of questions. They're going on Dr. Google and they're finding all the stories and the papers that may or may not be valid, and trying to help you navigate. And then we talk about the first 5 weeks, and that's, maybe when your child will have had an MRI and engage the neurologist, the plastic surgeon, the dermatologist. You can gather up all those team members. And sometimes, parents, families, caregivers, friends want to help, And you know what I tell them? I say, maybe you can be on a call with me and take notes so that I can remember what the team said to me. Or maybe you can, try to explain to the older sibling what's going on. Maybe take them to the zoo or do something for them. So people will help. It just may not be the way that they think they want to help you. Sometimes I tell them just go to the hospital, give blood, because that's really important. Your child may never need that blood, but you want to do something, go donate blood, so everyone wants to help. And then we talk about the 5 months, the 5 years, the 5 decades. And as you get further and further away from having a child born with a nevus, you're going to feel more comfortable taking care of the nevus. You're going to be you're going to be the experts, right? So I think, but the someone who asked me, like when the baby came to see us with a few spots of NCM, will my baby go to college? This baby is 3 months old. It's a little bit of a runaway train situation. So I for my own anxieties about other things, I try to use the rule of fives just to say, okay, we're not talking about the next 5 years right now. Let's think about the next 5 months. What are we going to need to do for the baby? We have to give them immunizations. We have to make sure they're eating well. So that's how I try to manage stress. And some people really do find talking with other families helpful. But just remember, even if your child has the exact same nevus that another child does, basically each child has their own playbook. They have a set of genes and a set of instructions that's very different. Even if it looks exactly the same on the surface, there may be different things going on. So, talk to people who are going to help you feel calmer. And if you find someone is getting your blood pressure up or you're feeling anxious, maybe that's not the person you should be talking with, and just say, thanks so much for your interest or your help, your story. I'll call you, if I have anything more, be polite, I guess. But, the most important thing is to give your child everything that you would if they didn't have a nevus, and, protect them from things that can be protected, vaccines, good nutrition, good medical care.
Thank you. The next question in the chat, any thoughts, feedback, or opinions on photodynamic therapy? It looks like a less invasive and easier option for the patient, done with local anesthesia, less surgeries, faster recovery, etc. The most known case is a girl from Brazil with a Batman mask treated by Dr. Popov in Russia.
I'll kind of go so far as to say that there are no long-term results showing that there's a long-term benefit. There was, and in the literature, report quite a number of years ago by a plastic surgeon using dermabrasion very early on to remove the nevus. And it had to be done in the neonatal period. And certainly that can lighten the nevus. The problem is that you see the child 3, 4, 5 years later, and that whole area is repigmented. And then you've got the addition sometimes of scar on top of that. So there's no magic answer to this. And, yes, you can lighten it a number of different ways. And there's some areas there may be some benefit of lightening it that are more difficult to treat surgically. But at the same time, the report out of Russia is, I think, at the very least, has not the follow-up to be able to show, that this really does much other than an early treatment. And the same thing happened. I mean, one of the surgeons who was involved in long-term follow-up of dermabrated patients, even the ones that were lighter, they had significant problems with retains with skin cysts and irritation and problems with hair growth within the nevus, even if it was lighter. So they were dealing with another whole set of problems. And the depth, recognizing why do we do anything like excision with expansion, is because if we're going to do the excision to a depth that's likely to get the greater part of the nevus out, it's going to be significantly deeper than any surface treatment is likely to do.
Thank you. Next one, do you think there will ever be a cure or oral treatment for CMN or NCM?
In terms of treatment, I think potentially. I mean, that's what the NIH trial is going to be looking at. The fact that we know some of the genetics of these congenital nevi, that gives potential treatment targets. We've got medicines that actually target the main pathway that we know is involved. So yes, then the question becomes, when does it actually make sense to use those medicines? And the early trials are not going to be looking at NCM, but I'm personally kind of excited by the potential for that to be helpful.
Yeah, 100%. There have been people who've looked at what happens in skin. Like there's a lot of inflammatory cells within nevi, and some children have more and get more scarring. And there's some kind of cells called mast cells that can cause a lot of the inflammation or contribute to it. So, 15, 20 years ago, there weren't any mast cell inhibitors. Now there are mast cell inhibitors. And maybe those could be helpful in children who have bad itching and bad inflammation in their skin. We tried to see if there were mast cells in the brain. We had the boy who had the seizure. We looked at his, the seizure surgery. We looked at his tissue to see if there were mast cells in there, and there were not. So we didn't think that was going to help. And now, as Dr. Coughlin said, the pathways are very much better elucidated. What caused it to happen, and in regular garden variety melanoma, non-NCM related, non-CMN related, there's this molecule called BRAF, BRAF as in Frank, and there are many medicines that target BRAF mutations. I wish our kids had BRAF mutations, because then there would be a lot more treatments. But we have the NRAS mutation, which is a little bit of the holy grail of medicine right now. But where I work, there are two people, one adult dermatologist and one neuro-oncologist like me, who does trials using agents that can target this pathway very early on in the way the pathway works. So we use those for children who have non-CMN, non-NCM related brain tumors. So that trial is going to start opening soon, and we've made a promise that we would add our patients to it for kids who have melanoma, CNS melanoma. Okay, so if you just have a few spots on the scan, that patient is not going to be eligible for this unless they have a documented CNS melanoma. So that may change the way we look at scans and the way how often we scan, because if we find that these treatments can actually treat a melanoma, then yes, maybe it is worth getting scans earlier or more often to see if anyone's kind of going on to develop that. But right now, that's not the case. But 20 years ago, we had nothing. Now we have a huge body. And I think Dr. Sargent was on here. Did I not see that? Maybe he left. But he's, doing some of the NIH work to look and see what these treatments are. I wasn't sure if that trial had opened yet. Dr. Coughlin, is it open?
Not yet. No.
Not yet. Okay. Yeah, I'm keeping my finger on the pulse of that, trying to make sure we get them the tissue and the stuff they need. But one thing is for sure, if there hadn't been patients who donated their tissue to the registries like Dr. Reyes's registry, our registry, we never would have gotten this far to be able to say what causes it, what we think causes it, and what we can do to treat it. So keep on giving us tissue if you can. It really does help. And, things that we tested for 4 years ago, we had a panel of genes that we tested for. It was like 40 genes. We're up to like 1,000 genes now. And so even if your child had testing, 4 years ago, it may be worth redoing that testing when there are more molecules to look at, because maybe there's going to be some other target. So, and we don't like to experiment on patients, but unfortunately, these are called clinical trials, and trials are just ways to get medicines out there. Children are typically almost the last of the bunch to get medications because everybody's so worried about hurting their nervous system or hurting their developing bodies well, actually, kids are just as important as adults. And if we know the risks, we can help patients make good choices about what therapies they can get. The caveat of that is that there are some places that are, touting medications that we've never tested, that have never been tried. And, they go to places, and again, I'm from, South Asia, and a lot of people think because I'm Indian, I'm like an herbologist and a homeopathic doctor. I'm not, but I would never say, don't go because it's unsafe. If it's something that's safe, if it's something that we think will be safe for your child, we have a whole integrative medicine center that we can work with to see if that would be something useful. I would love to find something, wonderful in a different world, but the way places do trials sometimes aren't the way we as doctors and scientists evaluate them. So, if you're Dr. Googling and you find something, send it to us. Maybe it's something we've never heard of before, or maybe it's something we have to say, please be careful. We've had a couple of kids go there and the outcomes are not good. So again, the internet has made the world a very small place in some ways, but it can be very confusing. So keep looking.
I want to come back to one other point that in the question that you asked me about before in terms of early, timing of surgery, early surgeries, and just to say that there is a surgeon who is pushing the idea of multiple partial excisions under local starting in early infancy, and published a paper on the subject. And each of the patients, the one that I've seen pictures of each of them. One of them I'm treating had 17 surgeries. Virtually none of the nevus was removed. Tremendous amount of scar tissue that was left there, and a much more complicated problem to treat. And yet this was a patient who was used as an example of how well the technique works. So there aren't any small, tiny procedures to do for these things. And we just have to again, coming back to the first question, recognize you need someone who not only has the experience, but understands what the problem is that they're really treating.
That's a great point. The last question that I received is asking whether any of you do telemedicine consults in case there's a patient who would like to see an expert, but they don't live in any of your areas.
All the time.
Yeah, same. And sometimes just know that if I have a telecall with you, I require that we have the MRI sent to us and that we have it presented at we call it a tumor board conference. Your child may not have a tumor, but we call it that. Just know that. My tumor board is usually Wednesday from 2:30 to 4 p.m. Eastern time. And my telehealths are usually Thursday afternoons or Friday mornings. So what we'll do is we'll discuss the case at our tumor board on Wednesday, and then I sometimes will have the telehealth with you Thursday or Friday to talk with you about what we found on the scan, how we can give you recommendations, and also to get you the information about our registry and about our other molecular trial. So that's my usual MO. And again, if we can't do it like the usual way, we'll either do a mail review or a peer-to-peer. Sometimes I've actually had patients' physicians come onto our tumor board to hear about their case so they can learn as well. We have, again, the world is so much smaller now that we have virtual meetings. We don't allow patients and families to join on those, but and then I've also had a doctor come into the telehealth with me from Idaho because their patient was in Idaho. So we had the whole team together, and I'm a very big believer in treating the whole family and the whole patient. So if your doctor is part of your team, or if you have a nurse practitioner or whoever, they can be on the call too. I just don't want like 40 people on a Zoom. I've had that once. It doesn't work. So I ask that you have about 2 or 3 people. But yes, we do telehealth.
I think for dermatology, we would prefer in-person visits, just because I think that is how we can evaluate the nevus best. I think that we do have colleagues all around the nation and all around the world. And so, if you're always welcome to, I think, see us in person. And we could also suggest maybe some local experts in your area that you could kind of build a relationship with as well.
I would second that. We're so visual and tactile because feeling the nevus is part of the exam, using our dermatoscope that looks like a magnifier but is a fancy magnifier. We can't do that, at least now, virtually. And sometimes what we'll do for folks is kind of tag team, right? So especially if it's an early in life one where ideally somebody's seeing somebody every 3 months, say, sometimes I'll see somebody at one point, then they'll see somebody local, and then they'll come back to see me. Or I am kind of a once a year check-in for folks and they're seeing somebody local in between. So we're always happy to partner with local providers if that ends up making sense. Or of course, there's the benefit of having the Nevus Outreach Conference every other year in person too, which is another time to connect with some of the folks on this call.
Fantastic. Well, thank you so much to everybody who joined us today. And on behalf of Nevus Outreach, thank you to all of the experts for so generously spending your Saturday afternoon with us. We really appreciate all that you do for the Nevus community and for your involvement with Nevus Outreach. And I'd just like to remind our participants that we'll have a 20-minute break now, and we'll reconvene at 5:45 Eastern Time for our Grassroots Fundraising for Impactful Change session, and that will be at a new link. So make sure you check the attendee portal. And Lauren, Lily, is there anything else you'd like to add or say before we leave?
Thank you again to everyone for coming, and we appreciate your involvement and hope this was beneficial to all who participated, both the panelists and the participants.
Yes, thank you again. We really appreciate it.
Wonderful. Thank you so much, everyone.
Welcome.
Have a
Thank you.
wonderful rest of your afternoon. See you later.
Thank you. Take care.
Bye-bye.